Can everybody hear me okay? The lights are very bright, so I'm going to try to look off away from them to pay attention to my talk. But thank you all very much for coming. And I'm going to dive right in because I have a lot to cover. I'm going to talk really fast, so bear with me. One thing that Linda didn't mention in introducing me, I actually have EDS as well. So for somebody that is specializing in physical medicine and rehabilitation, for me to be talking about diet and supplements is a little bit of a mismatch. I'm not a gastroenterologist and I'm not a dietitian. So my route to getting to speak about diet and supplements is sort of a wayward one, but it does have to do with the fact that I have EDS and many, many members of my family, including all 4 of my children, have EDS. So the first slide here is to bring your attention to the fact that I do maintain a Google Drive. And at the URL listed there, if you type that in, you'll be brought to a folder that has copies that you can freely download, share, and use as you see fit. Every talk that I have ever given for the Ehlers-Danlos Society, and even years ago when it was called the Ehlers-Danlos National Foundation, there's PowerPoint presentations. There are a few Microsoft Word files as well. If you want to explore those, it's best to actually download them and run them in the proper application because they'll look kind of ugly if you run them with the Google Drive interface. When I'm giving this through the rest of this talk, you might see an icon in the upper right-hand corner, and that's to kind of cue you that this topic that I'm talking about was covered in greater detail, and you may want to look in more detail at one of the earlier presentations. So, why am I even talking about this? Isn't this a hypermobility disorder? Isn't it really just about the joint and musculoskeletal system, the skin? What do gastrointestinal symptoms, nutrition, what do they have to do with EDS? Well, EDS affects the vital gastrointestinal physiologic processes, including digestion, absorption, elimination, and gut-related immune function. So gastrointestinal complications of EDS are common. They are potentially disabling. They are well documented in the existing literature, and they are vastly underappreciated by clinicians. Why do we have these issues? What are the causes of gastrointestinal issues? It can range from the abnormal connective tissue structure, growth, maintenance, and function that's inherent in EDS. This can make the GI tract sluggish, painful, inflamed, leaky, and it can lead to problems including dysmotility, which includes difficulty of movement through the GI tract anywhere from the esophagus, stomach, small and large bowel. It can also include functional gastrointestinal disorders like irritable bowel syndrome, chronic constipation, and evacuatory function disorders. Also, we have the autonomic nervous system. Even though that's the nervous system, it actually governs gut function, so it can cause gut problems. And then we get to the gut contains a population of microbes, and if that's out of balance, that's called dysbiosis. There's also gut-related immune function. There are cells and structure in the gut that governs immune function as a barrier, a selective barrier. It should let certain things in and keep other things out and function as part of our immune system. That can also be affected in EDS. So we have the autonomic nervous system. Dysautonomia is common in EDS, and it affects not only hypermobile EDS, but also other types. Think of fight or flight versus rest and digest. So people often think of the tachycardia of POTS and some of the symptoms that you get, but in reality it can also be the problem that is contributing to nausea, constipation, and difficulty with gastrointestinal function. Dysbiosis, this is when the balance of microbes living in the human body, for example in the gut, is disrupted and unhealthy. And dysbiosis is a rampant issue, a very hot topic in multiple fields of research today. The consequences of dysbiosis are not specific to EDS. Dysbiosis is actually problematic for anyone who has dysbiosis. It's important to realize the consequences include impairments in many, many functions that these microbes help us carry out, including fermentation of undigested carbohydrates, which then gives us a fuel supply of short-chain fatty acids. It can affect the synthesis of micronutrients that we depend upon, that these microbes are necessary for us to either metabolize or absorb, including B vitamins, vitamin K, folate, biotin. Absorption of certain minerals is governed or affected by the bacterial balance in our gut. Impaired lipid metabolism will cause poor absorption of fat-soluble vitamins. Metabolism of bile acids, steroids, and xenobiotics would be impaired, and that could cause significantly toxic results for people. Fermentation of non-digestible dietary residue or mucus would change the stool character in the setting of dysbiosis. Gut tissue actually produces neurotransmitters. There is more serotonin produced in the gut, in the enterochromaffin cells of the gut, than there is in the brain and in those parts of the central nervous system. That's pretty significant to indicate how our gut function can be affected by bacterial imbalance to affect things like serotonin, which is a mood regulator. When that microbial balance is disrupted, that means our gut-related immune function is disrupted. So dysregulation of gut-related immune function, how do we see this? This can be demonstrated in food allergies and other forms of hypersensitivity. We can have inflammatory or autoimmune disorders of the alimentary canal. This could include eosinophilic esophagitis, eosinophilic colitis, inflammatory bowel diseases like ulcerative colitis or Crohn's. And then there's the gluten-related disorders, including non-gluten celiac sensitivity or celiac disease. And then, of course, there's the mast cell disorders. I want to take a second to mention something here. I don't know that this has been brought up before, but there is a disorder that's receiving some attention in the medical community. We have heard mention of sort of a triad among a subset of people with EDS, where we see hypermobility, as evidenced in any of the EDSs or hypermobile spectrum disorders, accompanied by dysautonomia and immune dysregulation. There is a disorder called hereditary alpha-tryptophanemia syndrome, and there's some concern among some researchers that this actually may represent a tiny subset of people with EDS, that maybe what they actually have is hereditary alpha-tryptophanemia syndrome. I'm going to read you directly what it says off the NIH site that is accessible on the web, because it may strike a chord for some of you. Shared symptoms among persons with hereditary alpha-tryptophanemia syndrome can be associated with multiple organ systems and may be hard to explain. These symptoms may include allergic-like symptoms such as skin itching, flushing, hives, and even anaphylaxis. Gastrointestinal symptoms such as bloating, abdominal pain, diarrhea, and/or constipation, frequently diagnosed as irritable bowel syndrome, heartburn, reflux, difficulty swallowing, and connective tissue symptoms such as hypermobile joints and scoliosis. Cardiac symptoms such as a racing or pounding heartbeat or blood pressure swings, sometimes with fainting, as well as anxiety, depression, chronic pain, panic attacks, and others. These patients may find that others in their family have similar or related symptoms, as this is a genetic syndrome. So does that strike anybody as kind of interesting? So we see nutritional deficiencies and malabsorption in Ehlers-Danlos syndrome, but as I have said before, we are not what we eat. We see malabsorption in EDS, and that is multifactorial. It relates to those intrinsic abnormalities of the gut, the dysautonomia, the dysbiosis, the dysregulation of immune function, and it depends on what we eat and how we supplement. So we are not what we ingest, we're what we absorb. This is a more extensive way that I put it in a prior talk that I would really encourage you to look up. Again, it has to do with eating, digestion, absorption, metabolism, and elimination. You're not what you eat. So back to the question. If you've been diagnosed with Ehlers-Danlos syndrome, what diet should I eat? Should I take any supplements? It's a very reasonable question. It shouldn't be rocket science, but it seems to be. How many of you have asked that question of a clinician? How many of you got a reasonable answer? One? Somebody over there. On average, a primary care physician and some specialists have only 7 to 22 minutes per visit. They just don't have time. They're really not compensated to counsel you on these things, so it's not an incentive for them to bother. And the biggest problem of all is that there's actually insufficient knowledge among clinicians, and there's limited resources for them to actually understand enough about nutrition to teach you about nutrition in general. Most clinicians struggle to advise people about nutrition in general, so it's even more of a struggle for them to advise anybody about nutrition specific to EDS. So there's an article in US News and World Report just a couple years ago, and it emphasized that on average, US medical schools offer only 19.6 hours of nutrition education across 4 years of medical school. So this is the article itself stressing the amount of nutrition education that medical students receive continues to be inadequate. Here is a clinician from Harvard that is even more irate regarding this subject. So the bad news is that many clinicians are really not educated in detail about nutrition, and it's up to them to make the effort to learn about it after medical school and residency. So most often their advice regarding nutrition is generalized to major population issues like diabetes, high blood pressure, high cholesterol, triglycerides, just to tell you to emphasize a diet that's low sugar, low salt, low fat, whatever. Clinicians are not typically well equipped to address personalized issues related to things like food allergies, intolerances, functional gut dysmotility issues, or the risk of deficiencies that are inherent in self-limited diets. So this is an interesting little slide. So I hear laughter, so some people are familiar with this. It's that XY axis. The x-axis is increasing level of knowledge. So to the far left on the bottom, we have limited knowledge. When we move to the right on the x-axis, we have a greater knowledge, a greater wisdom and understanding about a topic in general, whereas the y-axis has to do with confidence. So what we see is all too often we have people with a low level of knowledge have a high level of confidence that they know everything. So unfortunately, some of the clinicians who have little knowledge and are not aware of how much knowledge they lack, depending on the phase of professional development in which they find themselves, they're firmly at the peak of Mount Stupid. So they're the ones that are likely to tell you really bad information about nutrition. The other issue that I see is regarding these resources, what we have to educate ourselves. Let's say a clinician that takes it upon themselves and they want to learn more about nutritional support for connective tissue. It turns out it's really hard to find literature describing a diet for connective tissue support. For example, this article was written in '97, so it's over 20 years old, and this is the most recent one I could find when I did a dig to see what if I wanted to learn more about nutritional support. And it's really not even generic, it's in a specific context of wound healing. It's not about just generalized building and maintenance and repair of connective tissues on the whole. So back to our question. Given the barriers to advising patients regarding nutrition, what might we hear when we ask this question? Unfortunately, this is what I think a lot of you have been most likely to hear. It's a bad answer. Part of a more appropriate answer would be to at least admit that we don't have any research to support that diet and nutrition are going to help us or obviously cure EDS. There's no studies that prove that any particular diet modification, inclusion, supplementation is going to directly address any of the deficits that we have in any of the types of EDS or hypermobile spectrum disorders. No studies have ever identified some sort of a compound or compounds that everybody with a particular type of EDS needs to eliminate. And there are no regulated medical foods that have a clinical indication anywhere in North America or Europe, including nutritional formulas, even some of the enteral feeding formulas, as well as the rehydration solutions. So if you take nothing else away from this talk, this is really how I think, this is how I give advice. This is, I think, a very reasonable approach to giving advice to nutrition and diet and supplementation in EDS, is that idea that EDS occurs in association with myriad secondary and comorbid issues, and many of these issues are significantly or even profoundly affected by dietary intake, nutritional status, or metabolism. So before you're looking to a doctor to tell you about diet and how to eat, it really gives you a huge advantage if you have learned yourself about basic human nutrition. You could probably learn more than most doctors know, because they've only spent less than 20 hours doing it, and they're probably not going to have the time to go do it now. So the more you understand about basic human nutrition, the more likely you're going to be successful in taking informed control of your nutritional status and improving your health. Realize that the ultimate goal of nutrition is to be able to provide your cells with the structural materials they need and the fuel they need to run. So nutrition includes the processes of dietary intake, digestion, and absorption. We should try to understand if it matters the way that we cook or prepare our foods. Does that affect the nutritional content? Does it diminish it if we prepare it in a certain way? And then we can dig a bit deeper and go down the rabbit hole if we start looking into whether it matters whether foods are GMO versus non-GMO, organic or non-organic, and then really start thinking about whether they're ethically sourced and what impact it's having on our world as a whole. So I'm going to blast through nutritional learning goals and topics. I'm not going to teach you everything that there is about nutrition, but I'm just going to show you the basic topics that would be goals for you to learn about, including macronutrients. First macronutrient is protein, and they can serve as a source of fuel, but they generally are providing you the building blocks, the amino acids that are reassembled within your body into other proteins. That would include things like structural molecules, including connective tissue molecules such as actin, myosin, and collagen. Transport molecules like hemoglobin, membrane proteins, these channel proteins that govern how nerve signals are carried in the nervous system. Hormones that are allowing the body to communicate from one place to another remotely by a hormone that circulates. Enzymes that have jobs to do to process things through metabolism and other parts of your physiology. Each amino acid has a classification. It's either considered essential, conditionally essential, or dispensable. Essential means that you can't make it. You rely upon eating it from a food source. You would not be able to make it from other building blocks that you have. Some of those essential amino acids really rely upon you not having a vegan diet. They come from animal products. That would immediately make you think that, okay, if I'm going to have somebody that has a vegan diet, I really need to know which essential amino acids would need to be supplemented, or how that person can strive to actually have a complete diet by combinations of vegan foods. Individual protein requirements are not an easy topic because it really varies even within an individual, not only according to their age, but whether they're in a catabolic or an anabolic state. This is a nice diagram. I would encourage you to look at it later because it sort of tries to summarize complete versus incomplete proteins. Another macronutrient, we talk about macronutrients in terms of not the size of the molecule, but the amount of it that you need. You need lots of protein, lots of carbohydrate, lots of lipids for day-to-day metabolism and long-term. Carbohydrates are your macronutrients that they serve as a fuel. They are broken down to glucose. The only exception is fibers that are not broken down to glucose. What we do with excess glucose, it's stored in the body so we can have an accessible form to pull some glucose from as glycogen, which usually goes into muscle or liver. And the remainder of the glucose we're not using immediately can be stored as fat. We need to learn how to understand what we're talking about when we hear good versus bad carbohydrates, and I would encourage you to become familiar with glycemic load and glycemic index. It's a very meaningful way to say not just how many grams of carbohydrate are there in something, but how much of it shows up in your blood and how quickly. This is an important diagram. I really like this diagram, so I've given you the link to it. And if I break it down, looking at carbohydrates and how they're categorized, to the left we have the simpler sugars, the monosaccharides, which are just the single ring, and the disaccharides, which are two rings bound together. Something to look at is the end result on each of those, the bottom. So monosaccharides often, they're those simple sugars that are easily digested. They get into the bloodstream rapidly. A little bit of fructose is going to give you a limited rise in glycemia, but if you get a lot more, it's going to be shunted into liver metabolism and cause problems, including fatty liver, insulin resistance, impaired glucose tolerance, high blood pressure. You know, you're hearing things like diabetes and high blood pressure from taking a sugar diet, not just a fat or a salt diet. And then you get into disaccharides. They also are shunted readily into high blood glucose and causing high insulin release, which will trigger hypoglycemia, which triggers this sort of labile high blood glucose, low blood glucose. It increases your hunger, it increases your drive to take in more sugar, and you get into a vicious circle, which leads to overconsumption. The same thing goes with the rapidly digestible starches that we see over on the right-hand side coming from the polysaccharides. They also lead to overconsumption in the same fashion. The slowly digestible starches are the good carbs. So they're slowly digested, they give you a steady glucose release so that you don't have this high insulin response. You get a continued sense of fullness, and it leads to control over your energy intake on the whole. All the way to the right, we have the resistant starches, which are resistant to digestion. We don't digest them, our cells don't digest them, but the bacteria and microbes living in our gut do. They're fermented, and they give you short-chain fatty acids as another source of energy. Those will increase your sense of fullness, and again, lead to energy intake control. So those are your good carbs. So that's a really valuable learning resource. I thought I wanted to include that. Lipids. Lipids serve as fuel. They are actually a more efficient fuel source, or a more valuable fuel source, in the sense that your lipids will actually give you more fuel than the carbs will, unit per unit. But they tend to be stored energy rather than rapidly burned fuel. And realize that we talk about saturated fats as if they're, you know, demon spawn, but they're really not, as long as you keep the amount less than 10% of your intake per day. Monounsaturated and polyunsaturated fats are fats that we need in our metabolism, and I'm going to touch upon a little bit of the omega-6 versus omega-3 fatty acids in a minute. Realize, bottom line, trans fats are unhealthy and they're bad, and it would be a nice learning topic for you to figure out why. Vitamins and minerals. Vitamins are organic molecules. They are considered either essential or conditionally essential. B12 is an example of an essential vitamin, and you cannot get B12 from plants. If you elect to have a vegetarian or vegan diet, you very likely will have to be supplemented with vitamin B12. Conditionally essential, like D, we might find some people with certain conditions where for them they're unable to properly metabolize or activate vitamin D, so for them vitamin D becomes an essential vitamin. There are fat-soluble versus water-soluble vitamins, and also, you know, we stopped letting nutrients into the club quite a while ago, so there are some vitamin-like nutrients that sooner or later somebody may define as essential, and so we might have some additional vitamins in the future, but an example would be choline or CoQ10, things that are found to be quite important, but not quite considered essential. Minerals are not organic molecules. They come off the periodic table. They actually originate in the earth. They cannot be made by living organisms, so they're all essential. It's just a matter of how much of them you need. So you'll notice that we refer to vitamins and minerals as micronutrients. We don't need grams of minerals or vitamins a day. We need them in like micrograms or milligrams. The bioavailability of minerals in foods and supplements varies dramatically. I kind of quipped earlier that, you know, we do recognize that many people are deficient in magnesium when they have EDS. We don't know exactly why, but that seems to be a pretty common deficiency. But the average clinician will just tell you to go buy magnesium off the shelf and take so many milligrams of it. And it's very poorly bioavailable, and the effect it actually ends up having is a cathartic. You will get what I would call projectile diarrhea if you try to aggressively replete magnesium with the wrong, poorly bioavailable source. So I'm constantly trying to tell people the difference between like a magnesium oxide and magnesium sulfate versus a chelated magnesium, which is highly bioavailable, very effective, and not giving you that negative side effect. There's the concept of enough of these micronutrients versus too much. There's the USRDA, and then there's the therapeutic upper limit, so we don't want to go beyond it. And then there's complex interrelationships between micronutrients, so that it's not as simple as saying just take a multivitamin. I really don't approve of just taking a multivitamin. I really approve of very targeted repletion based upon needs, because you can have competition between these micronutrients, and somebody that is actually deficient in one, taking a micronutrient may not be effective in getting it actually absorbed, because there's some interrelationships and competition that prevent that. So does everybody make sure they get plenty of water every day? So it's a myth. The general rule to say you should have 8 8-ounce glasses of water a day is completely false as a general rule for the entire population. I'd really encourage you to look at this. Snopes does a nice job of pointing you toward the actual literature and the scientific, very systematic review, questioning how did this ever get into the sort of general culture that we all have to be carrying around our water bottle and hydrating. Now, I don't want you to take that as me saying you shouldn't be drinking water. The point is that this as a general rule for the entire population is a myth, but certainly the average person doesn't need it, but some individuals may have higher specific requirements for fluid intake than others. It really comes down to one of the learning topics is being able to understand the difference between isotonic fluids and hypotonic fluids. Water is a hypotonic fluid. I think we got samples in the bag of a rehydration solution that is a much more isotonic fluid, which is much more effective. And what it means is your fluid volume that you have to take in is far less to be effective to have your intravascular volume and your hydration status be where it should be. So there's other things in food other than the macronutrients of proteins, carbohydrates, and lipids, and the micronutrients, vitamins and minerals and water. The only other thing that can be in food includes these hybrid molecules that are somewhat between, like glycoproteins, glycolipids, lipoproteins that are a mix of kinds of macronutrients. There's nucleic acids, that would be DNA and RNA. We can make those, so we don't depend on other organisms. We don't have to eat that in our food, but it does show up in our food. There are substances that we recognize as beneficial but not essential. They can include phytochemicals like caffeine, carotenoids, xanthophyll, flavonoids. There's anti-nutrients. These are starting to get scary. These are things that can interfere with your digestion and cause problems. They can include things like phytates, lectins, ATIs. There are food additives and fillers in things like pill, powder, and liquid supplements. These are called xenobiotics, and they can cause problems. I'll have somebody that'll come back to me and tell me, like, I'm allergic to magnesium. Well, you can't be. That is an essential, vital mineral in your diet. You're not allergic to the magnesium. You're probably reacting to something that's in the pill or the supplement that's a filler or added ingredient. There are substances in your food that can be recognized as toxic. The molecules on this screen include caffeine, BHT, which is a preservative, blue dye number 1, curcumin, and quercetin. So you need to understand what we mean when we're talking about the modern food industry. It's a busy slide. You can kind of look closer at it later, but it's that concept that when we go from something that's a fresh food that's not processed at all, what are the steps to take us from that fresh food to that food-like substance that we have? So in your breakfast bar or your snacks or your sugary drinks, how many steps do you go from the fresh food like the corn to get to that processed, ultra-processed food product? So homemade meals and dishes are much closer to fresh foods, whereas these ultra-processed products are the ready-to-eat, ready-to-heat products. So this very busy slide, you're not meant to read the whole thing. I just want you to realize that the top line is unprocessed foods, and then stepwise we go through minimally processed, processing culinary ingredients, processed food ingredients, and processed foods down to ultra-processed foods. And in the very bottom right-hand corner, among the examples of the most ultra-processed foods that have all these chemicals and these things that may be very hard for our bodies to break down or hard on our bodies is infant formula and baby food. So what are we doing with our Western diet and our modern food industry to our people? So the Western diet refers to this idea that we have lots of foods that are just overloaded with too much saturated fat, refined sugar, food additives. They don't have those healthy fibers, the healthy fats. And then since people may not get a lot of variety, they just keep going to the same fast food place or having the same ready-to-eat meal rather than cooking some nice home-cooked meal or some fresh food. We risk nutrient deficiencies given the lack of variety. This actually not only hurts our tissues, but it actually poisons those microbes that have such an important job in our gut. So even if you feel like it's not hurting you, it's actually hurting those bacteria, and it's really hard to get that balance back. It can affect your immune system. There's also an unhealthy ratio of omega-6 to omega-3 fatty acids. We tend to have an imbalance where there's more of the omega-6 than we need, and there's not enough of the omega-3 in our typical Western diet. And it's well documented, well researched, and proven that this Western diet is associated with numerous inflammatory conditions, chronic diseases, and early death. It's basically our supermarket diet or our airport diet and what you can grab and go and, you know, fast convenience foods rather than it takes work, it takes planning, it takes preparation to eat a non-Western diet. So this busy slide includes the omega-3 family represented on the left, the omega-6 family of acids on the right, and then down through the middle you're seeing a list of enzymes that help to break down those fatty acids that we start with. So the same exact enzyme can work on omega-3 family or the omega-6 family, and what we see as they're broken down, if you look in the middle, partway down, you see a light blue box and a pink box. The light blue box that is formed from the breakdown of the omega-3 fatty acids are more healthy. It's not the inflammatory cell signalers called eicosanoids. They include things like prostaglandins, prostacyclins, and the leukotrienes. That pink box that results from the breakdown of the omega-6 family are the main byproducts of the breakdown, and they are incredibly pro-inflammatory. So what this boils down to is when people are saying, take fish oil, take fish oil, take fish oil, they're telling you to take the omega-3 fatty acids, but that does nothing to the fact that you have these omega-6 fatty acids that we're taking too much of in our Western diet, that regardless of how much omega-3 you take that is good for you, you still have that excessive amount of omega-6 fatty acids that are bad for you. So your food intake, it matters that you should be taking foods that are sort of better balanced in more favoring those omega-3 rather than just eating whatever you want and taking a fish oil capsule and calling it good. So bringing it all back to the question, now that you understand, or after you've done some study, the basics of general nutrition, what does the literature say about nutrition in EDS? So if we go back and look, this was pretty much the first article that anybody really recognized. It was published in 2005. It was actually published out of the UK. And in this article, there was a nice table that was sort of suggesting, hey, we think these nutrients or supplements would be good for people with EDS. Brad Tinkle published a book, and within that book, he has mentioned his experience with nutrients or supplements or nutraceuticals and some benefits to people with EDS. This was published in 2010. And then the most recent article, and the third and only article we really can find if we do a deep literature search to find nutrient recommendations in EDS of any type, was published by Marco Castori and his colleagues in Italy in 2015. And it very nicely spells out the unfortunate fact that all of this information is purely speculative. There is no research. It is based on the idea that EDS comes with these conditions, things like early onset arthritis, fatigue, conditions that we're recognizing occur with EDS, and it's really just summarizing what the other authors have already said based on anecdotal experience or supposition, that since we do know what nutrients tend to help things like arthritis, then it would make sense that they'd be useful for people with EDS who also have early onset arthritis. It's really not research driven and very specific to EDS itself. So don't bother, this is the table, but do not bother looking in great detail at every single nutrient on the table because I did a little of that work for you. when I was trying to kind of look over this talk, because I've talked about this topic in previous years, and I was like, what can I do this time that's a little different, a little fresh? So I decided to do something that I do a lot of, which is I went on to Amazon Prime. And I took every single nutrient in that list, and I went big because I know that for a lot of our people, we need to have something that's hypoallergenic. We'd probably prefer something that is gluten-free or soy-free. Vegan is nice, and something from a reliable company. So if you were to get each one of those supplements in that table, it is $441.58 per month. That didn't even include the oral rehydration solutions that are isotonic. So also look at, unfortunately, what ends up on your plate. You know, you have a whole host of pills. I mean, those aren't really the pills. I didn't buy the pills. That's so again, now what do I do? So I advise my patients generally to eat in a way that doesn't aggravate these comorbid conditions. So when it comes to dysautonomia, I kind of can break it down for you here. I'd encourage you to look at it later, but it's saying drink isotonic fluids, avoid excessive amounts of hypotonic fluids, because that we want to keep the volume up in order to not trigger these dysautonomic symptoms. What about proteins that are high in catecholamine precursors? Since dysautonomia is driven by adrenaline, and some of these amino acids are precursors of adrenaline, if we have the wrong, you know, a lot of the proteins that may be driven into an adrenaline pathway, you want to eat low glycemic index foods and not get into that vicious circle of hypoglycemia triggering the desire to have, you know, to get jittery and anxious and get potsy or whatever and go to grab more sugar to bring it back up. You want to limit the bad fats, which contribute to insulin resistance, because again, that feeds into the whole sugar balance issue. And then there's some vitamins that are particularly relevant to POTS. If you have vitamin B12 deficiency, that's a big cause of POTS. We want to liberalize salts. There's some minerals that are particularly relevant to autonomic function, including magnesium, which I keep mentioning. And then there's other things, because the histamine load that you get in food, histamine loads will aggravate autonomic symptoms for many, many people. You want to eat to minimize your gut-related immune dysfunction. So we need to really pay attention to food allergies and intolerances, issues like the mast cell disorders and other antigen-induced immune reactions. We want to recognize cross-reactivity, consider using a food journal. We want to proactively avoid the notoriously inflammatory foods. We want to make sure we take care of that gut bacterial balance. And then we want to make sure that somebody's taking care of our dysautonomia, which is contributing to our gut-related dysfunction. I have lists of inclusions and increases and exclusions that you can take a closer look at in the interest of time that help you to keep a normal bacterial balance. Someday I'm thinking somebody's going to come up with a study that supports the use of fecal transplant to help people to address this dysbiotic issue in the gut. You want to eat to support digestion, absorption, and metabolism, and that's where you're going to see me saying you do need to be adequately hydrated. That's not equivalent to saying drink plenty of water. And you want to recognize these food allergies, but again and again and again, you see it emphasized you need to have this normal bacterial balance. I mentioned briefly here, consider supplementation with glutamine or consider the use of diamine oxidase. It's a case-by-case basis. Some people have found that glutamine really seems to help with some of their gut symptomatology. Glutamine tightens the tight junctions in between the cells, which is really kind of translates to it makes your gut less leaky. Diamine oxidase can help some of the people with histamine-related symptoms in the gut. Bottom line, eat food. A healthy diet that isn't stressing the Western diet or the modern food industry food choices is actually important for everyone. So if it's important for everybody, it's even more important for those of us with EDS. If anyone wants to take a glance, I have those 2 books with me if you just want to peek at it before you decide to go order it on Amazon Prime or something. Supplementation is commonly required, and my preference is that people get the majority, if not all, of their micronutrients from food. These deficiencies are really common in EDS, especially magnesium, B6, D, B12, and C. They can exacerbate symptoms of other conditions when you have these deficiencies, and they can be really challenging to address. They may even require somebody to give you an IV or a shot. If you're taking excessive doses of what is beyond the USRDA, I would consider that to be a drug rather than a supplement. And it's really, really critical to understand that some of these nutrients that seem to be beneficial for people, they should be recognized as a nutrient rather than a USRDA supplement. When you're taking supplements, you should take it upon yourself to make sure that your clinicians know you're taking these supplements. Don't wait for them to ask. They can have interactions with some of your prescribed drugs and affect other conditions that you may have. You might need a clinician to help detect or correct. There may need to be specialized testing, and there may need to be, like I say, parenteral repletion. Key is, sometimes it takes years to get unwell. Don't expect that when you take some supplement for a couple days, that it works immediately. It's not that kind of a relationship. And these expectations are going to affect your compliance. We need to respect individualized needs, including these things that we've talked about, like the food allergies and intolerances. We need to recognize these complex interrelationships. If somebody is dysautonomic or they have the gut-related immune dysfunction, all of those things have to be addressed because they interrelate to one another. You might have to consider exclusion diets on a case-by-case basis. When we question people in detail, there are a lot of people who realize they feel a lot better when they don't eat wheat. And I don't really care if your labs don't show a gluten abnormality. If you feel better without wheat, stop eating wheat. I actually recommend all my patients to try it with a strict diet without wheat for at least 3 to 6 months, but that doesn't mean no grain, and that doesn't, that means that you need to concentrate on nutritionally dense alternatives and try to get some of the nutrients that you could have potentially gotten from a whole wheat or a sprouted wheat diet. There may be other restrictions like dairy-free, lactose-free, corn-free, low histamine, no fermented foods, no nightshade vegetables, no salicylates, no tyramine, no MSG, low fructose, low FODMAP, ketogenic, anti-inflammatory, or autoimmune protocol, and endless possibilities of exclusion diets that help individuals. Any exclusion diet, though, you really do need to review with a clinician, and that would be a clinician who cares and takes a vested interest in you, rather than that one that's at the peak of Mount Stupid. So, it's never too early to start. I really like to see that we're diagnosing earlier and earlier and earlier, because we have to combat these things that are early factors in nutrition status for everybody. I can't emphasize enough how far behind we are on research regarding nutrition and diet. These are just 2 tools. These are apps that you can have on your phone or your tablet, and I've found them to be very helpful in understanding what food content has and helping people to deal with allergies and intolerances, and kind of realizing what the food that they just reacted to might have in it that they may have to avoid in other foods. So again, I covered a lot, and I just want to stress, I could talk about this for 2 hours at a time. Please do check out that URL, because everything I've ever done is up there, and you are all welcome to it. Please share it. Please encourage your clinicians to look at it. I'm around. I think we're going to take some questions, and I think we managed to just get in pretty close to the wire. So thank you.
So we only have time for a couple questions, so I'm going to just kind of summarize, because there's been quite a few on a number of issues. One is, what type of magnesium did you suggest taking?
So I'm pretty firm in my suggestion for magnesium regarding this bioavailability. I don't care which particular amino acid the magnesium is chelated with, as long as your magnesium is chelated. That's C-H-E-L-A-T-E-D, and that has to do with the bioavailability. To give you an example, if you go to your local pharmacy or like drugstore and you just grab a bottle of magnesium oxide off the shelf, for a 400 milligram dose of magnesium oxide, that is only 4% bioavailable. That essentially means that 384 milligrams of that 400 milligrams is just passed out of your body and not absorbed. So that's only 16 milligrams you're getting out of that dose. You are supposed to have about 25 grams of magnesium in your body, and I cannot do math in my head and tell you what fraction that is, but it means that if you're trying to boost your magnesium levels when you're deficient, that magnesium oxide is going to do nothing but give you diarrhea and hardly touch your level. The chelated magnesium is much more like 90% bioavailable, so you will absorb it, it will start helping you to rebuild your magnesium levels. There are other forms of magnesium that are considered bioavailable, but they have some drawbacks. Like magnesium chloride will give you an extra chloride molecule for every magnesium molecule that you get, and you don't really need that. And then things like magnesium citrate, if you take too much of that at once, it's pretty bioavailable, but if you take it, I hear laughter over here, so people know what happens when you take, it's a cathartic. I mean, we use it for people who are constipated to get them to blow everything out. So it's not a good choice. Chelated magnesium, I hear things like taurate, malate, glycinate, there's mixes of them. There's some theories that one is better than the other, but there's really no research to prove it. It's trial and error. And when somebody comes back to me and says, I tried that chelated magnesium and I think I'm allergic to it, my point is, again, you gotta look at the fillers. Was it hypoallergenic? And this goes for any supplement, so it was worth talking about when answering about magnesium.
One more, hopefully quick question, but it was asked a number of times. Is the relationship between EDS and the keto diet?
I don't know that we can say that there is a relationship. And again, I'm a rehab doctor. I'm not a nutritionist, I'm not a gastroenterologist, and I'm not an expert on the keto diet, but I know enough about it to understand it is a reasonable diet for people to try under the supervision of a clinician who can understand that is a very restrictive diet. And while some people have anecdotally explained just how life-changing the keto diet was for them and how much better they felt, there's a couple things about that. I might have a conversation with somebody when they're 2 months into it and they feel great, and then we talk to that person several months beyond that and they have crashed and burned. So you have to really understand there's more to it than just like this is the answer to everything. There are people that try the keto diet and they get very significant psychiatric symptoms. If you try a keto diet, that means necessarily that you are limiting your carbohydrates, and you do rely upon carbohydrates for rapid energy metabolism. Really kind of can affect the brain functioning and how you feel. So there's no easy answer on it. I do think it is a reasonable thing to try when other things are failed, but I do really think that you shouldn't just go doing it on your own without somebody to kind of go along with you to solve problems as they arise.
Thank you, Heidi. I just want to, if any of you have questions and you want to talk to Dr. Collins, if we can do it in the hallway, because there is one more session starting right now. Thank you.